interest in those who have an interest in acute or chronic PEs, they know that UC San Diego has been a pioneer in many things that many therapeutics that we have today in management of PE. I joined after my training at my current hospital or in Baylor, which part of that was also because they wanted to start a post-PE program. And I was fortunate to be here again at the right place. So I'm in no means an expert, but because I have a very small field, essentially Neil Bohr, you might have heard his name, is essentially said that as an expert is a person who has made all the mistakes that can be made in a very narrow field. So this is what I do mostly. I have no financial disclosures. You guys have already received the outline of this presentation. So let's begin by recognizing that a lot has happened in the past 20 years. In the early 2000s, we started hearing about your direct oral anticoagulants. That's why we don't call them NOACs anymore. They're not novel anymore. And that really changed the anticoagulation strategy for PE. Since then, we have had a few clinical trials that looked at anticoagulation and thrombolysis in patients with PE. And in the past decade or so, FDA has approved a few therapies, mainly catheter-directed therapies, including ECOS and percutaneous thrombectomy that we will get into. And now these are being fairly routinely used in management of PE patients. And PE response teams are also not a novel concept now in the United States. A lot of hospitals want to have a PERT team, post-PE follow-up clinics. And to expedite everything, COVID-19 taught us that ARDS and COVID itself is a risk factor for PEs. So I'm sure you guys saw a lot of thromboembolism in patients who were affected with COVID. And in US, COVID also kind of acted as a catalyst to increase the number of ECMO programs. And now throughout this pandemic, we saw an increased use of ECMO for patients with ARDS. And that kind of gave another tool to many hospitals to manage PE as well. So in light of everything, in 2019 and 2021, the European Society of Cardiology and CHEST updated their guidelines for management of PE. The other aspect is that not only is this an exciting time to be managing PE patients, you can save a young person's life if you recognize that he or she may be having an acute pulmonary embolism, because you hear about young patients dying all the time. All of a sudden, we think about a cardiac etiology, but what we don't think about is, could this have been a pulmonary embolism? The fact of the matter is that PE is still under-recognized. And I would say a part of it may be that most of us are focused on the heart. And I can't tell you how many times I've received a call from the cardiac care unit, the CCU. And the funny thing is, when I was preparing for this presentation, a cardiology colleague of mine called me and he shared a patient's case who was admitted for chest pain and NSTEMI. And she was undergoing the regular NSTEMI treatment and workup, and they got an echocardiogram, and that echo showed a dilated right ventricle with McConnell sign, which prompted the team to think, could this patient have a PE? And sure enough, that patient had a saddle pulmonary embolism with right heart strain, which was probably why this patient had presented. The other thing is that all the patients that are admitted to the hospital, I'm sure you guys do a good job in making sure that they're on thromboprophylaxis. Trust me, it's not trivial to start these patients that are sick on thromboprophylaxis, because we know that pulmonary embolism is actually the #1 cause, at least in US, of in-hospital preventable death when they look at the analysis. So these patients are prone, that are sick, to get clots, and it's important to make sure that you address that. The other aspect that we should think about is that there is a significant morbidity with these patients. A lot of these patients actually get lost to follow up, but a well-done study that was published recently in the New England Journal, it showed that about half of these patients that survive a pulmonary embolism, they have some sort of exercise limitation at 1 year. What exactly is that from? I think that needs to be determined and defined better. The other challenge that we face, especially here, is that we don't know which patient is the best to get a CTA. Because data shows that only 1 in about 20 CTAs done in the emergency rooms in the United States come back positive for a PE. That's a lot of CTAs that are being done for just being positive out of these. The fact is that symptoms are very non-specific. Chest pain, yes, traditionally we're taught that the patients have pleuritic chest pain, but a lot of these patients are not presenting with pleuritic chest pain from an infarct. They are presenting from their RV that's struggling, and that's very much similar to a heart attack. So chest pain, shortness of breath, diaphoresis, fever, fatigue, these are all non-specific. So you really have to think about PE to be able to diagnose PE. This was a study that showed increased likelihood of PE in patients that had hemoptysis or syncope associated with all these symptoms: dyspnea, cancer, prior history of VTE, recent surgery, immobilization. But I was thinking that obviously in Pakistan, when you have someone with hemoptysis, weight loss, you consider TB. So that again makes it a little confounding. This figure here, that was the same paper that I was talking about that came out this year, it kind of summarizes the current diagnostic approaches for patients that present in the outpatient setting or the ER. If you have a very low likelihood of PE, if you think it's less than 15% chance that the patient has a PE, you can just do a PERT score, and that can essentially, if it's negative, rule out the PE. But if your PERT is positive, or if you have a strong enough suspicion to think that you may have, that the patient may have a PE, you can choose any one of these strategies. Right now, you are probably familiar with the Wells criteria, the Geneva score, the revised and the simplified, and you probably have heard of many different strategies when it comes to D-dimer use, either using a D-dimer with the cutoff of the manufacturer, or an age-adjusted, or just a flat number of 1,000. So the bottom line is that all of these work relatively well. There is no head-to-head comparison between any of these strategies. So you pick a score that gives you the probability, and then you get a D-dimer, and then you pick any of these cutoffs, and then you basically choose that strategy for all your patients. Be consistent in your practice. Years criteria is something that was validated in pregnant patients. I like this because it considers 2 different cutoffs of D-dimer. So if you have none of these criteria is present, and your D-dimer is less than 1,000, then you don't really need to do anything else. But if you have any of these criteria present, and your D-dimer is more than 500 nanograms per milliliters, then you have not really ruled out PE. You probably should be getting a CTA. Going back to stratification, that was just a short introduction, background on PE, but because you guys saw in the outline for today's talk, we really want to focus on definitions, risk stratifying these patients appropriately. Why do we care? As you all probably know, that patients with pulmonary embolism don't die from hypoxia. It is the right ventricle failing that causes the patient's death that you're worried about. Those of you that manage patients in the ICU, RV failure is one of the scariest things that you can deal with in the ICU, because you don't know where the patient is in this spiral of death. Because when they have a systemic drop in their blood pressure, they're already over here and a lot has happened. Going from a drop in systolic blood pressure to cardiogenic shock and death, there's not much room here. So that's why it's important to classify these patients accurately. The classification that you guys might be familiar with, the American Heart Association classification, in my experience, is a terrible definition. The American Heart Association defines PEs as submassive or massive. And when they say submassive, they say a systolic blood pressure greater than 90, and any of these criteria that you see over here that suggest RV dysfunction. So it could be by imaging, echo, biomarkers, or EKG findings. So as you can imagine, you will have a wide spectrum of patients that are in this category of submassive PEs. I would argue some of these patients can actually go home despite being labeled as submassive PE, because they might have a troponin leak or an elevated BNP from something else, and they're totally fine. On the other hand, there are some submassive PE patients that really need some more aggressive interventions. On the other hand, massive pulmonary embolism, the definition is a lot simpler, that you have a systolic drop in blood pressure or a drop of 40 for more than 15 minutes, or if somebody has a cardiac arrest. The massive PE definition, although it's simpler, but it makes you wonder if massive has something to do with the size. So again, it creates some confusion. What's the best way to risk stratify these patients in today's day and age? Again, these are from the 2019 guidelines. Instead of using massive, submassive, you use a risk stratification based on their initial mortality. So if they come in with hemodynamic instability, their SPECI score, which is composed of these variables,
Dr.
age,
Abdurrahman, your
history.
voice has muffled a bit.
Okay. Um, Let me see.
Better
Is it
now.
better now? Better?
Fine.
Okay. I think somebody joined in. Okay, I'll continue. So going back to the definition of low risk PEs, so any of these criterias which have SPECI, that is, none of these criteria are present in the SPECI, and they have hemodynamic stability, they don't have any RV dysfunction on CTA, you call them low risk. On the other extreme, if they have hemodynamic instability, definition is the same as massive PE, which is a systolic less than 90, or a drop in systolic of 40 points or more for more than 15 minutes, or a cardiac arrest. And they have RV dysfunction, elevated troponin, SPECI that's high risk. Intermediate risk is, the only difference is that they have not dropped their blood pressure yet to less than 90, or they're not hemodynamically unstable, but they still have SPECI that's high, they have an RV that's kind of struggling on imaging, and they also have a troponin leak, that's called intermediate high. If they have any one of these where their RV is struggling, but their troponin is not positive yet, they will be still intermediate risk, but intermediate low risk. So I think it's important to understand this classification, because really it changes what you tell the patients in terms of the risk, and also what treatment modality you choose for them. So at this point, I think I'll give you guys a few seconds to look at this slide. And then just throw in answers in the chat. So let's say you have a young patient who recently had a surgery less than a week ago. So your surgeon tells you, no way you're giving anything that's going to make her bleed. You can give anticoagulation, but I don't want you to be giving anything else. And this patient is presenting with shortness of breath, chest pain. She has right leg swelling. Her heart rate is high. Her blood pressure is 93/74, and she's saturating 82% on room air. She appears diaphoretic. You get a CT angiogram, and then you find significant clot burden, and you find that on the CT scan, there is septal flattening, there's increased RV to LV ratio, there's reflux of contrast into the IVC, and you'd get an echocardiogram that confirms RV strain, and troponin for this patient is also elevated. So I guess the question is, how would you classify this patient? Would you classify this patient as intermediate risk or high risk? Interesting. Okay. So I think going back at this definition, let me see. This is the definition again. So this patient, this was a little bit of a trick question, because this patient appears sick. If you hear this story, you're worried about this patient, but what I threw in there was that the systolic blood pressure was still above 90. So by definition, it's hemodynamically not unstable. So he falls into the category of intermediate high. So that's what the point that I was trying to make, is that is there a gray line? But we do what we take what we have, and essentially I'm seeing some answers. Looks like some people would want to give half dose TPA, and some people are going catheter directed. So this is exactly why I think this is so fascinating, because get a you get a room full of 10 physicians, and then you'll have a different answer, and each one will have their own justification. But this is actually pretty close to a case that we had recently, and I'll show you what we did in that patient. So the management options that we have are anticoagulation, IVC filters. We have systemic thrombolysis, and then we have catheter-directed therapies. And then you also have the option of ECMO and surgery. So let's talk about each. Anticoagulation. So all your patients that come in with pulmonary embolism, they need anticoagulation. What has changed slightly recently is the recommendation to start low molecular weight heparin, because the PERT consortium database was analyzed, and they found that about 26 to 42% of these patients get therapeutic in 48 hours. So when they get IV heparin. So that's why the concern is that if you're giving IV unfractionated heparin, are you even anticoagulating? Because the data retrospective, yes, but it shows that maybe we're not doing as good as a job in anticoagulating patients with IV unfractionated heparin. So the recommendations are low molecular weight heparin. However, unfractionated heparin still has a role, because as low molecular weight heparin is subcutaneous, and when you give subcutaneous medication to someone who's in a shock state, they may not be perfusing their skin, so you may not get absorption. We also use IV unfractionated heparin in patients that are intermediate high risk, and we are planning to do any kind of procedures or pushing thrombolysis. This is kind of what the guidelines also suggest. So for patients that are high risk, I will reiterate the definition, because I think it is important for us to understand what I'm talking about. So high risk is hemodynamic instability. For them, unfractionated heparin. Intermediate or low risk, meaning either if they have RV strain or not, you can give low molecular weight heparin if you're going that enteric. But what about direct oral anticoagulants? So DOACs have really been a game changer since they came. They have reduced the number of patients that need admission to the hospital. You can, there's a validated score, HESTIA criteria, HESTIA, that is used in our ER. And it's essentially, it's intuitive, but we need to be a little more objective. So we have our ER residents do this criteria, talk to their attending, and then send these patients home and make sure that they can take a DOAC at home and see us in clinic. Direct oral anticoagulation may actually still be considered in patients that are admitted to the hospital and have a low or intermediate low risk. And this is a fairly new data that a recommendation that was published. The role of IVC filter, I am putting it under anticoagulation because I don't want to get into too much controversy. I will leave it at that. IVC filter has a role in patients that are not able to get anticoagulation. This is the JAMA paper that I was talking about. So if you look at what we just talked about, so you classify patients in low risk or intermediate risk or high risk. And if they are low risk and they can be sent home, you send them home on direct oral anticoagulants. If you have intermediate risk patients, you can either admit them, monitor them, and intervene based on how they do, if they deteriorate or if they get better. And finally, if you look at on the right side, you see high risk of hospital mortality, hemodynamic instability. This paper recommends ICU admission and thrombolytic therapy. So what is the data that we have behind thrombolytics? So the guidelines make recommendation that in high-risk PEs, again, hemodynamically unstable patients, class 1 recommendation to give systemic thrombolytics. In intermediate risk patients, they leave it open. See on the left side, they say, rescue thrombolytic therapy for patients with hemodynamic deterioration on anticoagulation. But they also say that we shouldn't be giving thrombolytics to all intermediate risk PEs, or the old definition, submassive, that again, I don't want to use that term because it can include some patients that are actually low risk. Intermediate risk patients, they leave it up to us to determine hemodynamic deterioration, because there is a lot of debate in the PE world what hemodynamic deterioration actually means. Because you can't have a swan in everybody and see that their cardiac index is going down, the RV is getting worse. So that is where the controversy comes. Uh, as we all know, uh, thrombolysis has a risk of bleeding, and there is absolute relative contraindication. But even in patients that we give systemic thrombolysis, we see some complications because it does increase your risk of bleeding. And then we have a trial that was done on intermediate risk PEs, and this was a very well done trial. It had over 1,000 patients. It's called the PYTHO trial, and it gave us a lot of answers. And what that trial did is enroll patients that had a PE, and our right heart strain, and a troponin leak. And their primary endpoint was hemodynamic collapse, or CPR, or drop in blood pressure. There, as you see over here, that most of these patients were classified as having right heart strain on echocardiography. But keep in mind, these are echoes that were done by echo techs, because I'm sure I heard that Indus has butterfly devices, and I think that point of care ultrasound is being used. Similarly, we have trainees that go and use point of care ultrasound, but we don't make major decisions. We actually get an echo tech and get a cardiologist to read that before we make any major decisions. So POCUS can help you in maybe moving you towards a certain direction, but you should wait for actual echocardiogram before we make any decision. What basically this study found was that there was a slight improvement in primary outcome of death or hemodynamic decompensation. So patients that got systemic thrombolysis, they did slightly better than those that just got heparin. But what was most concerning, and everybody took this from the study more than the benefit or the perceived benefit, was that the harm was significant. So a significant proportion of these patients had major bleeding, intracranial hemorrhages. And also there was a follow-up study that looked at this cohort 2 years after the initial study, and they found no difference in chronic thromboembolic pulmonary hypertension in these patients. Other studies were included in this meta-analysis. And what this meta-analysis, again, heavily weighted by the PYTHO trial, what it found was that thrombolytics reduced total mortality, PE recurrence, mortality due to PE, but there was, again, an association with increased risk of bleeding, increased hemorrhage. And the decrease in overall mortality was not significant in hemodynamic stable patients. I try to be good at this in terms of looking at some questions that come up. I think Javed Khan asked, where is the evidence of half dose TPA? Well, that's a very good question. You see this trial here called the Moffitt trial that used half dose TPA, but it is an extremely criticized trial. So to the point where their inclusion criteria and everything was questioned, and I don't think we should go off of that. But we know that half dose TPA, we don't know if it works well, but we do know that it has less risk of bleeding. Look out for PYTHO 3 trial, which is there exactly to answer your question, that PYTHO 3 will look at patients that will get weight-based thrombolytics in intermediate risk PEs, and that will be the max dose will be half dose, 50 milligrams, and it will compare it to anticoagulation alone. So we don't have a very good answer on half dose TPA, but it is practiced because the theory is that those patients that are at the edge of the cliff where their RV is struggling, you want to do something, but you're worried about bleeding. So it's just an arbitrary number of 50 milligrams. Let's give it. And maybe they have less bleeding risk and have some benefit. All right. So for that reason, where we want to benefit our patients, but we don't want them to have bleeding or any kind of adverse events, there has been a lot of work that is being done in the catheter-directed area. There are two main ways of doing this. One is the ECOS catheter. This is ultrasound assisted, not the actual access with ultrasound, but the catheter themselves have ultrasound vibration, and they have the ability to slowly infuse TPA. The other technology that is being used is percutaneous mechanical suction thrombectomy. There are many others which we probably won't have the time to get into, and they're not widely being used. So I think we'll stick with the ones that we have. So the guidelines in general for all catheter-directed treatments, they suggest that in intermediate risk PEs, you can use it as an alternative to thrombolysis. And that's a class 2A recommendations because again, we don't have large clinical trials to make it a class 1 recommendation. But these are again exciting times because those trials are being done, and I'll mention a couple of them. Also, the role of percutaneous catheter-directed treatment in patients with high-risk PE in whom thrombolysis is contraindicated or failed. So these are the recommendations so far. Again, I'm using the European Society of Cardiology guidelines, and this is where we are in terms of guidelines at this time. As I said, the ECOS catheter, this is the catheter that has that you can insert through the IJ or the femoral vein, and you can put one on each side, and you have ultrasound vibration. If you believe in magic of ultrasound, the theory is that it improves dispersion of the drug, and it improves the binding, and it also has these side ports that will slowly drip TPA into these clots. The data for this catheter began coming from around 2014, where they showed initially that there was an improvement in the RV to LV ratio. They also saw that the bleeding risk was not as much as systemic TPA. The Optimize trial actually looked at different infusion durations and different dosages. And in 2021, the Knockout PE registry that came out, they published the data of about close to 500 patients that had intermediate or high-risk PEs. Again, definitions being important. Intermediate are those that have RV strain, and high risk are those that already have hemodynamic instability. So in this cohort, they saw that it was a 23% reduction in the RV to LV ratio at 48 hours. And the duration and the dose that was required to reach that, the mean infusion time was about 10 hours, and the TPA dose was about 17, 18 milligrams in that time. Now compare that with 50 milligrams of TPA, which is half dose, and 100 milligrams of TPA, which is full dose. But what's interesting is that even a catheter-directed TPA has some bleeding rate, and that was found to be about 2.5% in this registry. So what's the future that we're all looking for? We don't have long-term data. We don't know if these patients, if they were given just anticoagulation, how they would have done. So we need some long-term data, good randomized controlled trials. And good news is we have a trial called HiPython. And this is Dr. Stravos, who's done the Python trial, and saw him virtually recently at a PERT consortium meeting. But essentially, he's going to compare ECOS catheter with anticoagulation in patients with intermediate high-risk PEs. So stay tuned for that. That's going to come in the next few years. The other device that has really gotten a lot of interest is the percutaneous mechanical suction thrombectomy. Again, there are a few different types, but the two main ones that you can see here, the one on this side, on the left of the screen, is called the Inari flow retriever. So it's you can see a manual suction device. These are pretty big catheters. These are 24 French catheters that are done under fluoroscopy. Either intervention radiology or intervention cardiology does this, and they essentially go in and suck out the blood. There's not a lot of rocket science. Essentially, you go through the fem and you gain access, and then you look at the clot, you do a small angiogram, and then you suck out the clot. The other device on the right over here, this got a lot of press initially because it's supposed to have AI that differentiates between blood and clot. Unfortunately, in my experience, it has had a lot of blood loss, and AI still needs a lot of improvement. It's a smaller catheter, but it's essentially that you get a lot of blood loss. The nice thing about this one, the Inari flow retriever, is that any blood that you suction out in this small syringe, you put it back into the patient. So it's kind of a bloodless procedure. There's a way to just separate the clot and return the blood. The idea being the same. This is the penumbra device, the one that I showed you on the right, that in the first 48 hours for patients that have intermediate or high risk PE, you want to improve their RV to LV ratio. So there was a reduction in the RV to LV ratio for these patients using the penumbra device, and the major adverse event rate was about 1.7%. The patient that we talked about in the question, the case that I had presented, it was a similar patient that we had, and we ended up sending this patient to get the clot out because they were okay with anticoagulation, but because she was post-op fairly recently, they were not comfortable with TPA. So we sent this patient to the cath lab and we got this clot out. So as you can see in the picture, this is very satisfying. You see the numbers improve in front of your eyes, instant gratification. Unfortunately, the Western world is very fond of instant gratification and we want it now. And you see the blood pressure improved significantly, the heart rate improved, the pulmonary pressures improved. So you see this in front of your eyes, so it's hard not to get biased after you see a few of these patients. So the data for this particular device, the Inari Flow Retriever, it came out actually last month in September, actually in 2022. And they shared the data with the use of this device for about 800 patients from the real world registry. And most of these patients were actually pretty sick, intermediate or high risk. A third of them had a contraindication to lytics. And they saw a 23% reduction in their mean pulmonary artery pressure. And they saw an improvement in the cardiac index and heart rate. And the adverse event rate was also fairly low, about 1.8%. Caveat being that these patients are very, these procedures are done by proceduralists that are very adept now. They have done quite a few of these. Is that Kashif bhai? That's asking what meta-analysis suggests outcomes with and without endovascular fraction in high-risk patients? Or there can be more than one Shazli. Okay, I'll try to address the.
जी अब्दुल मैं ही हूँ डॉक्टर काशिफ शाज़ली.
Just for people that are on the call, Kashif bhai is definitely, I have met him, and like Dr. Suhail said, and he's like a brother to me. So Kashif bhai, what's your question? Please feel free to ask the question.
Abdurrahman, just wanted to know whether there is some meta-analysis available comparing the patients, high-risk patient with and without endovascular abstraction with these devices. Is there any difference of clinical outcomes at the end of this of the patient's life? Is there any benefit of doing every time the abstraction, or are there some specific indications, you know?
Yes. So Kashif, I think I don't have the answer to this question because even there are no randomized controlled trials at this point. So this is very early on, and this is more of a situation where we have patients that we know we need the clot removed, but we can't give them thrombolytics. So if there are certain cases like the one that I shared, the case where we did not have any other options. So now it's a technology that's available and we have it, and so we use it. This is more of an ongoing clinical trial situation. So as I said, the data is in progress. So this is why, again, keep an eye for data that is about to come. The peerless trial that is going to look at patients that get this removal of the clot versus ECOS catheters. So this trial just enrolled its first patient a couple of months ago. To the same point, we don't have data. It's only that you see instant results on the table. And the proof of concept has been approved by the FDA. So these devices have enough single arm studies that have shown benefit, but there is no head-to-head comparison between anticoagulation alone. So that's the data that we're all waiting for. And again, as I said, once you get biased and you see a few of these cases where the patient immediately feels better, this patient came in with high flow oxygen, went to room air the next day, was able to go out of the ICU and go home rather quickly as compared to some of the other patients we see. These are very anecdotal experiences. I don't have concrete randomized controlled trials to back my claim. As I said, again, we don't know if long-term these patients benefit. Yes, you may save somebody's life in the acute setting, but we don't know if we have any long-term benefit in these patients, especially with regards to development of chronic thromboembolic pulmonary. What about surgery? So surgery still has a role. The recommendations are that if patients fail thrombolysis, or if there is a contraindication, you can go for surgery. Thankfully, our surgeon has not had to do the surgery more than once a year, maybe once every few years, because now, thankfully, we have so many other options that we don't really need to put them under surgery. There is one particular case where if somebody has a clot in transit and they have a PFO, then surgery is preferred if the patient is also high risk. We did a similar case with someone who had a similar situation. The guidelines on ECMO is where I would say are still lagging behind, especially in US, because the data, this is from 2019, the guidelines, and in the past few years, a lot of centers in US have started to use ECMO, and they have started doing ECPR, meaning that the patient comes into the ER undergoing CPR and they're placed on ECMO, and they immediately get worked up for why they had a cardiac arrest. And a lot of times they have a PE, which caused the cardiac arrest. So what we know is that systemic thrombolysis, before you put them on ECMO, it makes them bleed quite a bit. So the strategy that we have been using now is that if someone is coming in, has a cardiac arrest, is now on ECMO, and we find that they have a big thrombus that probably caused the cardiac arrest, we send them to IR or interventional cardiology to get that big clot out and get them off ECMO. So going to PERT, so PE response team. So the early data that we have so far suggests there's some better outcomes with centers that have a PERT team. What is a PERT team? Is essentially a group of different specialties, because as you see, you can have a lot of disagreements. You have pulmonary, you have cardiology, you have pharmacy, you have CT surgery, and you have interventional radiology, cardiology, and then you essentially have to come up with what the best plan is for the patient. So there are variable practices even with PERT teams, and this depends on what the perceived benefits and risks are in that center, and what the experience is at that center, and what the anatomy and the location of the clot. So I'll share with you the pragmatic approach that we have in our institute. So when we have a patient that's intermediate or high risk, the ER or the ward calls the PERT pager, and the PERT pager is answered by a pulmonologist. And we look at the case, and most of these patients will do fine with just anticoagulation. If they have intermediate or high risk PEs, or if they have intermediate high risk PE and we are worried about them, and this is again a very bedside assessment. You go there, you see the patient is tachycardic into the 130s, struggling to breathe, on high flow, syncopizing in front of you, but does not yet meet the criteria for high risk because their systolic blood pressure is 100, then we do something in that case. If they don't have any contraindication TPA, we give them half dose or systemic thrombolysis. If they have a contraindication to TPA, or they have a high risk of bleeding, and the clot is actually proximal, we use a catheter to suction out the clot. If they have a high risk of bleeding and the clot is too far out, we just leave an ECOS catheter in and hope that they get better. The reason why it's not very objective is because there's not a lot of data that looks at the risk of bleeding from TPA, and there's no score. So you have your Hasblood scores and other right scores that are there for anticoagulation, but you don't have good data to look at the bleeding risk from TPA. These are all the factors that have been well studied and are associated with increased risk of bleeding if you give someone TPA. We do the patient selection case by case, sending most of these patients for anticoagulation alone, but in select cases, those that we think are going to deteriorate in intermediate risk PE, for some sort of intervention. Now, what about high-risk PE? They're already hemodynamically unstable. They already have shock. They already either have a cardiac arrest. These are very scary patients. We manage them in the ICU with extreme caution due to the effect of intubation on hemodynamics. Almost half of these patients have immediate post-intubation CPR. So we try to avoid as much as we can to intubate these patients. So most of these patients will do well with high flow. At most, we'll give BiPAP because that also has some positive pressure. So we're a little reluctant to do that. If you're moving towards mechanical ventilation, ECMO is always a consideration. And then your usual drugs that you use to support ICU patients, levofed to keep the blood pressure up, and dobutamine as your inotrope. In some cases, you can use inhaled nitric oxide to improve to decrease your afterload for the right ventricle. And then we consider ECMO, as I said, if we have increasing, escalating pressure requirements or worsening hypoxemia. If we are considering ECMO, we are also considering systemic TPA. So patients that get systemic TPA, most of them will not go on ECMO. Again, case by case. But if there is a patient that we are considering thrombolysis or reperfusion therapy, and they're stable to get ECMO and then just get the clot out, then we go ahead and do that instantly. Okay, so shifting gears finally very quickly to the part of my job that does not require as much as adrenaline rush is the post-PE follow-up. So pulmonary, most of the clinics, post-PE clinics are run by pulmonary because most of these patients complain of shortness of breath. Our job is to make sure that their right ventricle has normalized. They don't have any other reason why they have shortness of breath. And then at about 3 to 6 months, we get VQ scans. And in some patients, we do right heart caths. And why do we do all of that? Because after you have a PE, these are all the different buckets that you can fall in. And really what you can do about is there's what the population that you can do something about is chronic thromboembolic pulmonary hypertension. So we are making sure that they have survived a PE, getting better. They are compliant with their anticoagulation. They don't have any other reason to be hypoxic or short of breath. And then some patients will undergo right heart catheterization and have pulmonary hypertension. Why do we say that? Because we have treatment options for CTEPH. Now, this is a very complicated surgery, and it is not available everywhere. Even in US, there are only a few expert centers that do this. We started a program at my institute, but my training was in the pioneer of this surgery. So University of California, San Diego, a pulmonologist actually came up with surgery, and Dr. Jamieson, who is a CT surgeon, and some other before him, really fine-tuned this technique. And this is a surgery that was mind-boggling to me when I first saw it, because they let us scrub in the OR and actually see what they do. Essentially, they cool the patient to 20 degrees, and then they take them off bypass. So there's complete circulatory arrest. There's no blood flow whatsoever. And that's when they take out the chronic clot. And certainly surgery has been shown to have a survival benefit, improve your quality of life. Patients go off oxygen and improve your hemodynamics. So it can be curative. So that's why it's a big surgery, but patients that undergo the surgery, they do very well. Patients that are not surgical candidates, they have the option now of balloon pulmonary angioplasty. It is exactly what it sounds like. It is angioplasty of pulmonary vessels done by cardiology. It was pioneered in Japan, but now a lot of centers in the US are doing this. Those that can't get angioplasty or surgery, and even some that do get these treatments, they are put on vasodilators. Riociguat is the drug that is approved here. The rest are off-label, and then we use anticoagulation. This is the kind of clot. So it showed you a picture of acute clot. You saw how red it was in fresh clot, but that cannot be removed by IR or interventional cardiology. This cannot be removed by IR or interventional cardiology because, as you see, this is a lot of epithelialized clot, and it has chronic scars that really need surgery to be removed. And this is courtesy of my prior institute, CSD. They divided into levels. And Dr. Madani, who is undisputed best surgeon right now on the face of earth that does these surgeries. He published this paper where he showed that this is probably the best approach to treating CTEPH. So patients that have disease in the main pulmonary artery, lobar artery, and I think only Dr. Madani can reach segmental arteries. Arguably, maybe some more people are getting better. Then you can opt for surgery. But if you have subsegmental or segmental blood vessels, then you essentially can consider balloon pulmonary angioplasty. But for microvasculature clot, really blood anticoagulation and vasodilators are the treatment of choice. So I think we are pretty much close to the end of time. So I'll stop here and share my conclusion and leave some time for questions.
Thank you, sir, very much. जिनको भी questions है anyone, raise hands and we'll go one by one, inshallah.
I have one question more. Abdurrahman, what data suggests regarding catheter-directed intra-arterial versus intravenous thrombolysis? Is any difference you found in your practice?
So for the sake of pulmonary embolism, these are all catheters that are directed into the clot and they have side ports. So essentially you only get venous access. So you only get IJ or FEM and you go all the way to the clot. And then you're trying to get your catheter through and through into the clot. And there are side ports in that catheter that will slowly drip your TPA. So essentially, there is no arterial aspect. So pulmonary artery, but the axis is venous, and then you go into the pulmonary artery.
Yeah, definitely this is the way, but I just wanted to know whether intravenous, direct intravenous, a peripheral intravenous TPA versus direct catheter directed thrombolysis, is any difference between these two, the outcomes?
Okay, I get your question. Unfortunately, there is no head-to-head trial that has ever been done. I don't think it will ever be done due to industrial ways of things that are done in these kind of trials. But physiologically, it makes sense to me that if someone is essentially needing TPA, it's quicker for me to just push systemic 50 milligrams of TPA. The only time that I'm worried about someone is when I'm worried that that patient might actually bleed with even 50 milligrams of TPA. So in that case, as I showed the data, that the dose requires for catheter-directed TPA is very low, like 18 milligrams. So in those patients, and then if they have clot that's very distal, I will send them for catheter-directed TPA. So in my personal practice, very few patients get catheter-directed TPA, mostly if they have distal clot, because our proceduralists have gotten very good at getting the clot out by suction thrombectomy.
Can I ask a question?
Sir, go ahead, sir.
All right. Thank you very much to the organizers, Dr. Suhail Akhtar and his team, and of course, Dr. Abdul Rahman for a wonderful talk. I just have a quick question for you, that what is your experience of PERT team at your institution? And does this team involve other specialties like cardiology, interventional radiology? Of course, pulmonary and ICU, I think, is a part of it. But what is your team and what is your experience with it pre and post PERT at your institution?
So I was part of two different models. The first model didn't turn out very well. The first model was when a PERT consult was called, everybody got on the line and had something to say. And unfortunately, as you can see, because there is not a lot of concrete data behind a lot of the modalities that are available, no offense to intervention cardiologists, but an intervention cardiologist will want to do an intervention. Whenever we would have a PERT consult, we would have a lot of differences of opinions. So that model, that experience was a fail. And what we move towards is that we make the pulmonary the captain of the ship. So essentially the pulmonologist, they have already had meetings with the intervention cardiology, the intervention radiology. So now we know what the selection criteria are and which patients will be taken to the cath lab. So we use those criteria. We're trying to protocolize it a bit more. And then we essentially make that decision for the patient. So the pulmonologist evaluates the patient, risk stratifies the patient, recommends the treatment. Most of the times that treatment will be anticoagulation alone. But if we decide that this patient should go on ECMO or needs further therapies by IR or interventional cardiology, then we make that call. So we are kind of the triage and the decision maker.
And does this service includes ER as well as inpatients?
It's available only for ER and inpatients, yes. So if somebody comes in through the ER or if someone decompensates in the ward.
Thank you.
Professor Javed Khan has asked a question: duration of direct oral anticoagulation in unprovoked PE.
That's a very good question, and I have a very funny saying that just came, is that not all provoked events are the same. So if you have a knee replacement surgery and you have a PE, that was a very strong provoking event. But if your grandmother had a knee replacement and you went to visit her for a 6-hour flight and then you had a PE, that's not a very strong provoking event. And this is essentially saying that not all provoked events are the same and not all unprovoked events are the same. I actually have a slide somewhere. Let me see if I can pull that up for the anticoagulation. The duration is usually, let me pull that up and then I can, it's basically, the duration is either lifelong or 3 to 6 months. And CHEST guidelines in 2021 actually made another change to the recommendations, saying at 3 to 6 months, if you are worried about a patient maybe not having a very strong provoking factor, you can actually do half dose of anticoagulation of the DOACs. And I'll be happy to share those references as well. Let me put that slide in the meantime. This is a slide that was shared by my colleague and I liked it. And this is kind of one of the things that I think I can share. This is a colleague that is in University of Michigan. This is his, and I do pretty similar. So no clear provoking factors, extended anticoagulation, consider half dose. Cancer associated, you extend anticoagulation, usually full dose, weakly provoked, half dose anticoagulation, strongly provoked, short dose anticoagulation. This is from the CHEST guidelines in 2021 that have really changed a lot of our practice, where we are now considering half dose of anticoagulation as opposed to full dose for even those that we're considering lifelong.
Thank you, sir. Another question by Dr. Muiz Salahuddin. If high-risk patient, high-risk PE and patient is on pressors without ECMO available, would you diurese to optimize RV preload? Second is, how would you bridge anticoagulation after giving systemic TPA?
So I will tell you what the physiology tells you. If your RV is huge, it's going into the LV, and you are worried about a physiologic situation of extreme RV failure going into LV and decreasing your LV preload, diuresis makes sense. I would also tell you that I have not had any intensivist that has been excited about pushing IV diuresis. because the other alternative is that what if you are in a situation where you're actually preload dependent? You give the patient Lasix and they just lose all that. And so I think it's a question that really, and I remember 2 years ago, there was a paper that actually looked at this and they found that this may actually be beneficial. But in real life, I've had a lot of resistance to even suggesting diuresis. And since we've had ECMO, fortunately, we've not had to have that that intense discussion. In terms of bridging anticoagulation after systemic TPA, you basically give TPA and hold the anticoagulation until your PTT is less than 70. And then you start anticoagulation with heparin, IV heparin. The other thing that's interesting is fibrinogen. Some centers, after they give systemic TPA, they look at fibrinogen levels. And if they're less than 100 or 150, they go ahead and give cryo, and then start IV heparin. But none of that has been well studied or validated in any of the trials. So the bottom line is that go with PTTs. After you've given your TPA, you may or may not check your fibrinogen level depending on your institutional protocol. But the most important thing is PTT or 10A, and then restart anticoagulation.
Okay, Dr. Wahid Shah, I think he's from Quetta. He's raised his hand. Wahid?
Thank you, sir, for such a nice presentation. I would like to ask, okay, if a patient present with the massive pulmonary embolism with hemoptysis, so then what will our approach will be to thrombolytics? And if you can share your experience as well. Okay, if a patient present with massive hemoptysis because of pulmonary embolism, so should we go for thrombolytic therapy or not?
So if a patient with
Hello?
massive pulmonary, hello?
Yeah.
Yes. So if a patient with massive pulmonary embolism presents with hemoptysis, it'll depend on the amount of hemoptysis. It's very rare to have hemoptysis with PA that has burst. Most of the times, the hemoptysis is from a small infarct or a PE that is causing not a lot of hemoptysis. So, as you all know, as pulmonologists, we cannot agree on a definition. But I think from my experience, I've never had massive hemoptysis from PE. It's usually an amount that I'm okay with pulling the trigger on the appropriate treatment.
Okay, thank you.
Dr. Salim Ahmed. Dr. Salim Ahmed, you have a question. I think you have raised your hand.
It is Dr. David Khan who's also raised his hand before him.
Dr. Zafar has asked a question, sir. What is the incidence of serious complication with systemic thrombolytic?
Depends on the dose. If you give 100 milligrams, again, your bleeding risk is intracranial hemorrhage and major bleeding, right? So going back to that slide, which even the PYTHO trial that used 100 milligrams of TPA with anticoagulation. So the caveat with PYTHO trial is that they kept the patient on full dose anticoagulation, and on top of that, they gave 100 milligrams of TPA. And in that arm, they saw about 6.3% bleeding rate from extracranial site, and major bleeding was actually 11.5%. And what was again very concerning to me was the intracranial hemorrhage that was around 2%. It doesn't sound much, but if you see someone with intracranial hemorrhage and you caused it, you just feel really bad.
Dr. Madiha has asked a question. Can AI algorithm modify and make PERT more effective or performance? I don't know what she means.
Yeah, I think this is an AI viz and other AI algorithms that are being used to basically If a CT scan is done, a CTA is done, and the algorithm AI is recognizing that this patient may have significant clot burden, and what it does is essentially brings up that patient's file on the radiologist's screen so that radiologist can actually read that sooner. And then as soon as that it's read, it basically prompts all the members of the PERT team. But yeah, it's something that again, the AI companies that have developed these algorithms, they are trying to sell it, but I'm not sold yet. Because I think I've seen a few patients that AI had categorized as trivial PE or a small PE, but when you looked at it, it was actually pretty significant.
Salim Ahmed, do you have any question? Dr. Javed Khan, sir.
Can you hear me?
Yes.
Yes, sir, we can hear you, sir.
Okay. I was just asking a very simple question or a very practical question. We are working in a country where there is a lot of post-tuberculous bronchiectasis which present with recurrent hemoptysis. Now, usually we go for an HRCT to see if there is any evidence of this post-TB bronchiectasis there or not. But once we get a CT scan, which HRCT, which is completely normal, and the patient is a low risk, do you think we can exclude pulmonary embolism, or we have to go again for a CTPA? Because you see, we have a lot of financial constraints also in this country. So what will your choice will be that once we have done an HRCT, which is negative, yet the patient is having frequent recurrent hemoptysis, how should we proceed?
It's a challenge, right? I don't have a great answer. It's similar to what we deal with in our ICUs, where patients are admitted for long periods of time. They have a pneumonia, and D-dimer is not going to be helpful because as you have patients similar to bronchiectasis and the ICU patients, they're already chronically in an inflammatory state. So their D-dimer will always come back positive. So honestly, I don't have a great answer because VQ scan will not give you the answer either if you have an abnormal imaging. So it's probably going to be the degree of hypoxia that you're worried about, and if you think that this patient, that's why it's interesting that all of these criteria is based so much on the clinician's suspicion. That's where I think credit goes to all the physicians who look at these patients as a patient and not just particular D-dimer or a certain clinical parameter. So if your clinical suspicion is high enough to where you think that this patient's symptoms are not adequately explained by just bronchiectasis, then I think it's still worthwhile pursuing other diagnoses. But one of the criteria in this is PE most likely diagnosis, right? So that increases your probability. So this is again, this will be left up to your clinical judgment.
Thank you very much, sir. One last question. After this, we will wind up with the final remarks from Professor Suhail Akhtar. Last question is from Dr. Tala Shehzad. How do you follow up a patient after stopping anticoagulation at 3 to 6 months, either D-dimer testing, echo, or CT contrast? What do you prefer?
Yeah, if we are stopping anticoagulation in a patient after 3 to 6 months, that means that patient had a very strong provoking factor. So you don't really need any kind of follow-up. And the risk of recurrence in patients that had a very strong provoking event, it's essentially, it's very low. So I am very confident in actually discharging from my clinic and saying, well, you had a knee replacement surgery, which prompted your clot, and you're cured, and you don't need more than 3 months or 6 months.
Thank you very much, sir. Now, final words from Professor Suhail Akhtar.